Good morning, everyone. Thank you very much once again to all my colleagues attending the Pernambuco 2021 Liver Talks webinar. It's a great pleasure to begin this scientific event today with a Liver Talks contribution from King's to hepatology over 25 years in alcoholic liver disease news challenge. It's also an honor to have my colleagues, Dr. Luciano Beltrão Pereira from United Kingdom and Leticia Nabuco from Rio de Janeiro, who will moderate this round table with me and will introduce the international speaker, debaters, and presenters of the clinical case. My special thanks to Professor John O'Grady, who was a senior lecturer, consultant, and professor in hepatology, and also substitute Professor Roger Williams as a director of Institute of Liver Studies, King's College Hospital. We also prepare a small tribute to celebrate the Pernambuco Silver Jubilee. Welcome to the last Liver Talk 2021 today.
15 anos do IFP, Instituto do Fígado e Transplante de Pernambuco, e 25 anos do Congresso Hepato Pernambuco. 2 datas, 2 motivos para celebrar o conhecimento. O IFP tem muito orgulho de participar mais uma vez da organização deste evento, que reúne especialistas do mundo inteiro. Já foram mais de 150 participantes nacionais e 60 internacionais de várias regiões do mundo, dos 5 continentes que já participaram deste, que já está entre os maiores congressos nacionais na área de hepatologia. Grandes nomes da medicina internacional e nacional já estiveram no evento, o que deixa a gente que somos os nomes por trás do IFP muito orgulhosos e felizes por saber que estamos no caminho certo, o caminho do conhecimento. E é também em nome de todos aqueles que nos ajudaram nestes 25 anos que estamos aqui para agradecer 25º Congresso Hepato Pernambuco e 15 anos do IFP. Conhecimento que ultrapassa fronteiras.
Okay, now I'd like to introduce Professor John O'Grady. As I said before, John now is a professor of hepatology and will be delivering his talk about the contribution of King's in the pathology of 25 years. Welcome, John, to our meeting once again. Now it's in the webinar, but it's a great pleasure to have you here.
Thank you very much, Leila. It's a pleasure. Congratulations on 25-year Jubilee. That's a wonderful achievement. Next 15 minutes or so, I'm going to reflect on, as Leila asked us to do, King's contribution to hepatology, and I'm interpreting that in quite a broad sense, including transplant hepatology as well as conventional hepatology, and also with a lot of outreaches and routes into other basic components of our care. And really, all of this, if you can have the next slide, please. This is all a credit to Professor Roger Williams. He set up the liver unit at King's in 1966 and spent 30 years there before he moved on. As you all know, sadly, he died last year, but in fact, yesterday was the anniversary of his death. So we still miss him. And a lot of this is a credit to his vision and his work. So if we can have the next slide. The philosophy of the unit that Roger set up was to have a fully comprehensive clinical service and delivered within what I call a liver hospital within King's. That's to say that it was very important to him to be independent, not to be reliant on other people to deliver and develop a service. He needed to be in control to progress and develop services. And he also recognized that a lot of the work that he was subsequently to do was dependent on having a lot of patients available. So having an excellence in clinical liver hepatology drew a lot of patients, which then themselves fed into the clinical studies and the science. He had close links with a pediatric service, which in its own right developed to international excellence. He also had the foresight to see the need for an internal dedicated histopathology service that worked exclusively in liver. And he made a wonderful appointment with Bernard Portman, who again sadly passed away 2 years ago. And he delivered a wonderful lifetime service to liver histopathology. His relationship with radiology was slightly at more arm's length, but it was a very, very strong relationship. But probably his stroke, his genius, was to develop an acute liver failure unit, which started off as the 2-bedder unit, which was what I worked in first when I went to King's in 1984, and then developed into a more than 20-bed service, which remains functional in King's to this day. So if we go to the next slide, it will start to talk about the pet project that Roger had, acute liver failure. And I joined in, as I said, in 1984, and even then, the understanding of acute liver failure was relatively basic. Here I highlight etiologies, and the point I want to make is that even in the early 80s, it was not recognized that paracetamol-induced acute liver failure was a totally different disease to all the other causes. There was some overlap, but it was fundamentally totally different. And again, drug-induced acute liver failure is very different to Wilson's disease, is very different to viral hepatitis, resulting in acute liver failure. So from the 1980s onwards, a huge amount of progress was made in understanding the condition of acute liver failure and the many intricacies that have an influence in outcome and management. Next slide, please. One of the most fundamental differences was to recognize that there were apart from etiology effects, there were 3 distinct subgroups within acute liver failure. The rapidly progressive one that brought with it very rapid progression to grade 4 encephalopathy, but equally early intervention with spontaneous regeneration. And this pattern was best typified by paracetamol, acetaminophen, but also the hepatitis A and some with hepatitis B. And this was the first break in understanding that this subgroup of patients, if managed properly, had a reasonable chance of surviving spontaneously. At the other end of the spectrum, if you had late onset or subfulminant hepatitis, which was much more slowly progressive, less dramatic in terms of the clinical sequelae, appeared to be less severe, but in fact had a much worse outcome. So bringing together the etiological issues and these subclassifications, we went a long way to getting a better understanding of the natural history of acute liver failure. And built on that better understanding, developed a range of strategies to try and improve outcomes. This, I think, speaks volumes. It's survival curves of all patients admitted to King's with acute liver failure from 1983 up to 2013. And you can see that there's steady incremental improvement in hospital survival. And I'll come back to talking about the role of transplantation in this. But if you take a condition that when Roger started working in it had a mortality of a survival rate of 10%, and 30 years later that is up to 75%, that I think is an incredible testament to his life's work in this condition. Next slide. So Roger's main passion was liver support devices. He really believed that liver dialysis was a real concept. And at the time of his death, we all know that this has not been delivered as a clinical service with consistent results. And I'm going to start with the charcoal hemoperfusion study that was designed and delivered in the first part of the 1980s. And the strength of this, I'm going to speak to this, is that I want to talk about something that was designed nearly 40 years ago. And it basically classified the patients into those who had grade 3 or grade 4 encephalopathy at the point of entry into the study. It and basically looked at two durations of treatment, either 0, so it recognized the need for a no treatment group, and then it had 2 durations of treatment of 5 and 10 hours. Now, the bottom line results are in both studies, both grade 3 encephalopathy and grade 4 encephalopathy. You can see that there is no difference whatsoever in the outcome with charcoal hemoperfusion. And that really was a great disappointment for Roger. But it is still probably one of the best designed clinical studies of an extra corporeal liver support device. And some of the lessons learned from this have been lost in later studies. So next slide, please. And strengths of this study, and if you compare the studies that have been done in the last 10, 15 years, this is still as good, if not superior. Large number of patients, single center study. The more centers in the study, the more difficult it is to deliver a positive outcome. Huge enrollment, 87% of 158 consecutive patients enrolled. Early randomization, delivery of treatments, if they were randomized to that, included an assessment of standard of care, and tested hypothesis that duration of treatment was relevant. So if it is worth going back to this old study to remind ourselves of some of the very key and important lessons that we should reflect on and remember when we're designing studies. Next slide, please. With every iteration of a new liver support device, Roger's enthusiasm would always go sky high. He would always think this was the one that was going to deliver the holy grail of extra corporeal support. And this particular one is ELAD. So it's a living cell, it's a tumor cell line, hepatocyte, but ultimately, you know, after 30 years of various types of treatment approaches, this has not broken through. And pertinent to the theme of this section of the meeting, Leila, is that this has been most effectively tried in acute alcoholic hepatitis and really is not successful in improving significantly survival. And the next slide is looking at another of the devices that was very extensively tried. It was used in clinical practice quite extensively, really before the scientific evidence for its efficacy was established. And this is an albumin-based dialysis. The concepts are strong, and some of the studies, like others, are picking up and pointing to some elements of efficacy, but it too has failed to demonstrate in improved survival with treatment in all types of severe liver disease, acute liver failure, and acute alcoholic hepatitis. So we are still in a position, I think there is enough evidence from these to suggest we should continue the search for a device that is effective, but at the moment we are not there. And if we move to the next slide, I think this is going to summarize. Next slide, please. The lessons that we have learned from liver support device studies. And I'm just going to make the point at this stage that millions and millions of dollars have been spent on conducting these studies. So it's very expensive, very difficult. And none of the endpoints in any of the studies has achieved a p-value of less than 0.05 in terms of survival. However, I alluded to this briefly a moment ago. Secondary analysis in a number of these studies have made valid observations of benefits in subgroups. And those are the findings and observations that need to be carried forward in the next iterations of the clinical studies. These subgroups observations make sense when you think about them. So I think there is encouragement here rather than total discouragement from the bottom line failure of survival benefit. The main and recurring theme is that these devices may improve survival through transplant benefit. So they're bringing patients to transplantation in better condition and getting them through transplantation. So maybe we should be thinking about them as allied interventions as opposed to completely different interventions and pathways. Next slide, please. So one of the other things that was clearly important as transplantation came into acute liver failure was the need to predict outcome at an early stage. It's a difficult issue and continues to be difficult. So you have to make very rapid decisions in a progressive critical illness. And if you make the wrong decision, if you select a patient for transplantation who really doesn't need it, that's an unnecessary transplant, and that patient survives, if they survive the transplant, with a burden on their health that they would not have had they been allowed to survive spontaneously. And it's also an organ that could have been used in somebody else. The other end of the spectrum, if you get the prediction wrong and you predict somebody will survive and they die, then that is a very clear failure of decision-making. But equally, there are wrong decisions being made in the positive group in patients being sent forward to transplantation when they actually don't need it. So this is another thorny issue, difficult issue, and we haven't cracked it yet. But it is one where we have made a lot of progress. So the next slide refers to what are the King's criteria published in 1989. These have not stayed static. King's has continued to work on profiling prognostication. And if we can move on to the next slide, we will see the latest work from King's, Will Burnell driven, which is doing a number of very sensible things. It has developed a model which uses more criteria, but also it recognizes that things things move on from the day of admission to the day after admission, either because the condition is progressing or the patient is responding to interventions that do affect the outcome. And this kind of dynamic prognostication that doesn't take a fixed set and expect it to work equally well in all patients at all time points to one that reflects these interventions is a very, very good way of thinking. And this is very complex. I'm not even going to try to explain it. I'm not sure I could, but it is being very, very rigorously evaluated, both internally at King's as well as externally. It combines a day 1 model with the day 2 model. And again, if we can move on now to the next slide, you will, we should be seeing ROC curves here into the AUC curves for the performance of the model, both day 1 and day 2. And these results are very, very good. The more favorable assessments of the King's criteria pitches them at about 0.7, and these are really up to almost 0.9. So what Roger has started with acute liver failure has continued through in the hands of Will Burnell and is making great progress. Next slide, please. So as we know, liver transplantation made a very significant impact on outcome in patients with acute liver failure. The first consideration for transplantation for this condition was in 1984, when the NIH held a single topic seminar on it. So that is relatively recent, because up to that point, it was considered unlikely to be feasible, never mind successful. We now know that is not the case. So next slide. The outcome of all cases admitted to King's over the period of time is now presented to you again, broken down into 3 groups: the hyperacute and subacute. And each of these is subdivided into those who died, those who survived spontaneously, and those who survived through transplantation. And I think this is a very simple, but it's a very powerful message. So for subacute subacute liver failure, liver transplantation delivered all of the improvement in survival effectively. In the hyperacute patients, improved medical care made the biggest contribution to improved outcomes. And the bottom line here is that now 70% of patients who are admitted to hospital with acute liver failure should have and over that, and that figure is going up all the time, should have an expectation that they will leave hospital alive. A phenomenal advance. Next slide, please. So the other area that Roger made a huge impact was in transplantation. This is a breakdown of transplant activity in the UK. And he recognized transplantation as a feasible intervention in 1966, 67. And joined with Roy Kahn in 1968 to do the first liver transplants in the UK. And the King's program went on to become huge, transplanting over 250 patients a year. Cambridge program is also thriving still. Roger wasn't ultimately, in the longer term, happy about this. He felt that the country would be better served by a higher number of smaller centres that delivered more regional-based treatments. But that's a relatively small point. Next slide, please. So, where King's and Roger have been incredibly have contributed a huge amount to hepatology is in transplant hepatology. And I'm not going to go through any of these in any great detail, but starting with working out indications for transplantation, which now are the bread and butter of our understanding, but was something that was not well understood in the 80s and even in the 90s. Another major contribution was in defining patterns of rejection. And although the standard rejection processes are reasonably well understood now, there is still some lack of understanding into the true role of immunology and immunological injury in disease after transplantation. He was very active in immunosuppression studies. He always wanted to get his hands on the newest drug, particularly a drug then known as FK506. But he also, at the same time, understood that not everybody needed immunosuppression lifelong. So he did a immunosuppression withdrawal study in the early 1990s. So you could see the spectrum from both ends. Disease recurrence, King's made a huge contribution. It's most famous for being the first to describe recurrence of PBC, albeit only in 3 patients. But recurrent disease has since been extremely well investigated, for example, in hepatitis B. So King's was responsible for recognizing fibrosing cholestatic hepatitis and working through a range of issues, including very, very good scientific work on the pathophysiology of this condition. A lot of very good work came out of King's with recurrent viral hepatitis. Again, for example, is the name associated with this, and the immunoglobulin strategies of hepatitis B in the 80s were very novel and forward-thinking. The final area that I think King's has contributed an awful lot is in the lifelong immunosuppression strategies. Mindful that immunosuppression for 10 years or 20 years does not come without a cost. And the changing tolerance or lack of tolerance profiles with time after transplantation and the consequences of individual drugs bring a dimension to the management of these patients in the second, third, and fourth decade after transplantation. And a lot of the thinking, the good thinking on that was influenced by these studies. Next slide, please. In conventional hepatology, a lot of good work came out of King's. Again, I'm going to go through it on the basis of a list with relatively brief comments on each. But in the 80s, very good work was done and published, some of it published in New England Journal of Medicine, demonstrating the role of azathioprine in the long-term maintenance of patients with autoimmune hepatitis. One might think that's a relatively trivial contribution considering where we are now in this condition. But at the time, this was very, very important. Immunosuppression studies in PBC. Again, he persisted with this, even though the concept was discarded early because of the side effects of steroids when used in the 60s. He tried both with cyclosporin and with azathioprine, a limited success, some success in terms of response, but again, not translating into clear long-term clinical strategies. King's was one of the first to embrace aggressively injection sclerotherapy in the management of varices. And here David Westerby did wonderful pioneering work in association with a Brazilian fellow whose name escapes me, who did fantastic studies on the anatomy of the vascular system at the lower part of the esophagus. Halothane hepatitis is a condition that has vanished, but it has vanished because of halothane hepatitis. And this, in the late 70s, early 80s, King's did wonderful work in this area, both in terms of the clinical condition, but also in understanding the immunological drivers of it. The clinical service at King's is noted for its flexible multimodality strategies for managing HCC, not the rigor of oncological approaches, but a more flexible strategy that evolved as the patient evolved through the condition. Another area of note, very powerful work done at King's, was in bone disease in patients with PBC. And there are many other relatively small projects that were highly effective at the time that contributed to Roger having over 3,000 publications in hepatology across the entire spectrum of the condition. And many of these are embedded in the way we practice hepatology now. Next slide, please. So here, to sum up, I have posed two questions. Why did it work? Why did King's become famous for excellence in hepatology? But followed by another question, would it work now? And this allows me to go into some, well, comments on reality or on history, but also some changes in the philosophy that have evolved. So it worked because of the huge number of patients that were coming through the system. International fellows would come, be assigned to a particular disease, and in their first 2 weeks, probably see more patients with that condition that they ever saw in their lives before. There was a critical mass of interested clinicians and scientists, some by appointment, some by people who looked at and recognized what was happening as very good and powerful and became involved. Naturally, you have to attribute this to very strong leadership from Roger Williams, but also the flow of what I'm going to call hungry, if that's acceptable, talented international fellows. And Leila, you're an excellent example of this. So you came to King's, young, enthusiastic, you liked what you saw, you worked hard, you got an awful lot out of it, and you contributed a lot. And if you look around the world, there are so many people that fit this mold who are now very, very famous, many of them at the end of their careers like myself, some even retired or dead. So that was a real contributor to the success of the King's Review. Why wouldn't it work now? Well, it was over-reliant on self-funding. So Roger didn't like this structure of applying for grants, of tolerating the rejection or the significant change in these. So he was an entrepreneur and he raised a lot of money that allowed him to give himself freedom to support the work that he wanted to support and support it quickly. For young fellows coming through now who want to do some research, however, there is a requirement for a much more structured approach to their training. And a lot of the work that was done simply couldn't be done now in the way that it was done then. And there are clinical governance considerations. So the way liver fellows would put in intracranial pressure monitors, do dialysis without any cover from neurosurgery or nephrology, quite simply wouldn't be accepted nowadays. So it's a model of delivering clinical practice that has passed. And my final observation is that nobody now, I think, is prepared to work 100 hours per week, which wasn't a case of where we were prepared to. If you were staying at King's in my time, you had to. So next slide, please. In summary, I have developed this topic around Roger because he is responsible for so much of it. It's right and proper. There are others who obviously have contributed very significantly, but it was a project driven by him. And since his departure from King's, it has broken down into different structures. Some of it has survived and thrived, some of it not necessarily. But nevertheless, the legacy of Roger, the legacy of King's to hepatology, I think is real and will last for quite some time. Thank you very much.
Thank you very much again, John, for a very nice presentation. I'm very proud to be a fellow in my PhD student there in King's and come back to King's many times and keep our exchange program with our institution, King's College. And now I could see Luciano come back to be his trainee there for transplant team. I have only 5 minutes to open this section to any question for John O'Grady, because I think it's very interesting to know what's the Liver Institute brought and they take to the all part of the world, many fellows, good relationship, publications. I know that Roger was a king for that, but he created a big team like you, Graham Alexander, Alex Gibson, Nigel Heaton, and many others that is impossible to mention here, but it's very nice to be a fellow at King's. I'm so proud and happy to have you here in our meeting today.
And King's is also very proud of its fellows. So we're an international community. Roger was very good at hosting a meeting in ASLD in November, typically in Chicago, to bring people together, and he loved those meetings. And I think when any King's Fellow bumps into a King's Fellow anywhere in the world, naturally the conversation goes back to King's.
Any question for the Brazilian friends would you like to ask John? Because I have moved on to Professor Vijay, that he's already lying here. No one?
Thank you, Leila.
Okay, John, thank you very much indeed. I think I have moved on to Luciano to introduce Professor Vijay. Vijay, it's a pleasure to have you here, and we have our Brazilian friends that we introduce you, and very nice to have you and share your experience in alcoholic liver disease to our Brazilian hepatologists.
Thank you so much.
Luciano?
Professor Vijay, Shah, thank you for having you here with us in the event. Professor Vijay is a consultant hepatologist, professor and chair of the Department of Internal Medicine in Mayo Clinic in Rochester. Thank you, and he will present.
So my talk will be for about 15 minutes to make sure we have enough time for the debates that follow. I'll talk a little bit about the epidemiology trends in alcoholic hepatitis or alcohol-associated hepatitis. We'll talk a little bit about pathophysiology and therapies with a special focus on the interface of alcohol use disorder and alcohol-associated liver disease. I'll comment that Doug Simonetto, who is also on the panel, is my partner. We do many of our studies together. And we heard from Dr. O'Grady how important it is that we build the next generation to carry on the work of the current generation. And so I feel very confident with Doug, who is a Brazilian, that he'll be carrying on the work for many generations even after him. So with that, I will start, and Doug will be doing the panel discussions, and I will give the formal talk. So this slide shows you the global burden of alcohol-associated liver disease. The amount of alcohol use of approximately 2.5 billion people in the country or in the world, and alcohol use disorder in about 250 million of those. And then subsequently compensated cirrhosis in about 25 million of those people. Decompensated cirrhosis, another 10% of that, 2.5 million. And then the deaths you see from not just cirrhosis, but also hepatocellular cancer deaths, which is overall accounting for about 1% of all worldwide deaths. In this slide, this is from Elliot Tapper's group at Michigan, shows a lot of information about epidemiology trends of alcohol-associated liver disease. I will just point your attention to the lower graph that looks at sex. And the important points here, you see the prominent increase in alcohol-associated liver disease mortality in women, as well as individuals who are at a young age in their life. And these are both important trends that now have been validated in many subsequent studies and are a worrisome pattern of increasing alcohol complications in young people and in women. Another point that has gained a great deal of attention recently, this is analysis done by Dr. Arab, who JP, many of you may know him. He's from Chile. He also trained in our group, has been doing great work in Chile. And he modified or incorporated the information about BMI and alcohol and the interplay to make some recommendations about levels of drinking that would be considered hazardous drinking, and broke this into BMI less than 30 and BMI greater than 30, and by gender in men and women, and stratified according to the amount of alcohol that might constitute hazardous drinking. And you see that really if you are BMI over 30 and female, even more than one drink per day is putting you in a range of hazardous drinking. So this starts to lead us to the discussion about managing excess alcohol consumption at multiple levels. This is a nice pyramid that was published in the Red Journal a few years ago, really outlining the different approaches that are needed at a population level as opposed to at the high-risk population itself. So in the general population, we know that education is important, but education is not adequate. And in fact, much of the impact will be through public policy, including alcohol taxation, minimum unit pricing, and limited alcohol availability, limited marketing. And on the other hand, in the high-risk population, we need much more aggressive interventions, and I'm going to show those in some of the subsequent slides. But this includes behavioral therapies targeted towards high-risk individuals, and pharmacologic therapies as well. So as we start to move into the interface of alcohol use disorder and alcohol-associated liver disease, it's important to understand the contributors that lead to inadequate treatment for individuals with alcohol-related liver disease. This is shown here. We know that there's a shortage of providers who have capability to provide alcohol use disorder and alcohol-associated liver disease care, and that there is very lack of multidisciplinary interaction to facilitate the care for these patients. We know often there's medical and psychiatric comorbidity and complexity. We know, at least in the United States, probably in Brazil also, that there are geographic disparities, and individuals in very rural areas, as well as individuals in underserved urban areas, have disparities in care. And I showed you there's an increasing prevalence of the condition And in the United States and perhaps in South America as well, there's a stigma associated with this condition that reduces the motivation for people to seek care. This is a conceptual design of what an ideal care model may look like for individuals with alcohol use disorder and alcohol-associated liver disease, where the patient is in the center and the specialist, the primary care physician, and the home to manage the chronic situation, use remote care and telemedicine to facilitate 24/7 care, and then multidisciplinary clinics for intensive management on site. I mentioned telemedicine, and to me, telemedicine is just one component of the broader discipline of digital medicine. And this has also been referred to as M-medicine or E-medicine. And especially in this group of individuals, there's many opportunities to help individuals to understand when they may be having craving and to target therapies and prompts and nudges. I might call it as a digital nudge to help people to avoid falling into the traps that lead to excess alcohol use in real time through phone apps and other technologies. So with that discussion about alcohol use disorder and alcohol-associated liver disease, I will transition now to some of the therapies that are under evaluation. For this talk, given the limited time, I'm going to focus mostly on the therapies that are ongoing in the United States, focusing under the NIAAA consortium that is sponsored by our government. First, I will cover a little bit of the pathophysiology in this cartoon. You can see that alcohol leads to problems through three organ systems or systems. One is the intestines, where we know alcohol increases gut permeability and leads to these PAMPs. And the PAMPs will eventually go to the liver. Also causes direct damage to the hepatocytes, which releases DAMPs. While PAMPs are related to bacterial products, the DAMPs are related to injured cells and molecules released by these injured cells. These in turn activate what's referred to as the inflammasome, which leads to the release of chemokines that bring in immune cells and have functions on other resident liver cells that in turn lead to fibrosis, inflammation, and portal hypertension. So the goal of the NIAAA consortium, referred to as ALCEPNET, is to test new therapies, study from cohort studies, the epidemiology, etiology, risk factors, natural history, and then identify mechanisms as well. This slide goes over all of the different studies going on. For the sake of time, I won't be able to cover all of the studies ongoing, but this gives you an idea of the different buckets in omics, immune pathways, extracellular vesicles, the microbiome, clinical pilot studies, and then different models and imaging. I'm going to show you a couple of the key studies or trials that are ongoing through ALCEPNET. One of them is relating to the molecule anakinra, which is an interleukin-1 receptor inhibitor. There's many other drugs that are acting through a similar way, in which ultimately you're blocking that inflammasome that I showed you earlier and reducing the inflammation from neutrophils that is involved in alcohol-associated hepatitis. So this is the signature trial of the ALCEPNET. The GCSF arm was dropped, so really it's just a prednisolone versus anakinra, and this trial is progressing nicely. Dr. Simonetto is one of the principal investigators in this study. And then another study that's more Mayo specific is the interleukin-22. And this is a molecule that's produced from blood cells and is involved in liver repair and liver regeneration. And it has effects not just on hepatocytes, but also on stellate cells as an antifibrotic molecule. And this is the data. Again, Dr. Simonetto was critical in this study as well, showing the open label dose escalation study showing beneficial effects of IL-22, a fusion protein, a form of IL-22 in patients with alcohol-associated hepatitis. Note that this is an open label study, and the randomized controlled trial will start likely end of this year or the beginning of next year. And this is the criteria we'll use in the next study, really similar study design, studying low disease severity and high disease severity and dose escalation. But this time we will have a placebo arm or a prednisone arm to compare the results of the IL-22. And recently we just published a paper in Nature Communication that targets chemokines, and this time using a unique way whereby we're actually targeting what are referred to as super enhancers that regulate the production of multiple chemokines, and in that way can block, for example, CXCL1, CXCL6, and 8, and thereby reducing the neutrophil infiltration that we know is pathognomonic of alcohol-associated hepatitis. So as I start to move to my end of the talk, I want to talk a little bit about some biomarkers work that is also ongoing through the ALCAP-NET network. And again, Dr. Simonetto was critical in many of these studies I'll show you as well. We know that within these vesicles is contained a number of unique cargo, including sphingolipids, proteins, microRNAs, and perhaps some of these may be involved not just in as a biomarker, but also as the pathophysiology of the disease. We know this from both human studies where we isolate vesicles and from animal studies where we isolate vesicles and study their role in the disease process. And this is just an example. This paper was also published recently showing that extracellular vesicle counts are associated with increased 90-day mortality in patients with alcohol-associated hepatitis. And if you stratify patients according to a cut point, that you can show a difference in mortality of patients who have high numbers of vesicles, portending a worse prognosis compared to patients with low numbers of vesicles, suggesting that the vesicles may have prognostic significance. And as I come to the conclusion here, a couple summary slides. This slide starts to look at strategies to mitigate impact of alcohol-associated liver disease at 3 levels: global level, local regional level, and individual level. And this is from a joint publication with Dr. Sumit Asrani and Jessica Mellinger, and I believe Dr. J.P. Arab was on this paper as well. And so we looked at a global level, we outlined broader society-wide alcohol reduction and national monitoring. And I mentioned some of the pricing strategies, availability of alcohol, and restricted promotion. So really at a policy level, these kind of interventions are needed. At a local regional level, early identification of the condition and extending care to high-risk individuals, population screening for alcohol use disorder, and a variety of technology approaches to help these individuals that I discussed through digital health. And then finally, at the individual level, individualized treatment for alcohol use disorder and alcohol-associated liver disease. And we discussed the multidisciplinary clinics. We discussed, well, we didn't talk about care coordinators, but this may be a pathway. But we talked about some digital approaches that may serve the same purpose as a care coordinator. And I didn't get to go too much into pharmacotherapy, but combinations of pharmacotherapy as well as cognitive behavioral therapy, motivational therapy, and these items we discussed as well in terms of comorbid diseases and digital interventions. So this slide is just to highlight the transformations in technology that are occurring and that can allow us at multiple levels to help our patients and make healthcare more patient-centric rather than provider-centric. With that, I will conclude. And this is some of the individuals in the research lab who are doing some of the laboratory work. This is Dr. Molly's group who collaborates with us on the translational studies. This is some of the members of the UO1 consortium. And then Dr. Simonetto and Dr. Kamath, who are my longtime collaborators. And then there's JP and Tejasav. So I will conclude there. Thank you.
Thank you very much indeed, Professor Vijay. It's a pleasure here to have Professor Yao just on here. Arun, it's very nice to have you here in our meeting.
Good to be on. Vijay, long
Yes.
time no see.
Okay.
And I'd like to introduce other moderator. That's Professor Leticia Nabuco. She's a doctor in the hepatology of Hospital Universitário Clementino Fraga, da Universidade Federal do Rio de Janeiro. And she going to present the first presentation case to be debated later on. Rodrigo, welcome as well. You in Iceland, enjoy the weather in Iceland. You in the holidays. Thank you very much indeed to participate in our meeting today.
Thank you. It's very nice. Thank you so much. I think I sent you my presentation just in case, because I didn't know how the Wi-Fi was going to be here. So
Yeah.
Sim, então chama a professora Andressa Teixeira, professora da Faculdade de Medicina de Ribeirão Preto, da USP.
Good afternoon. I want to thank Professor Leila, first of all, for the kind invitation. It's a great pleasure to be here. And Professor Vijay and Professor O'Grady, it was a wonderful to hear from you. And have said that, let's move on to the first case. It's a 52-year-old man presented with fatigue, mild abdominal pain, and progressive jaundice that had persisted for 15 days. The patient had a history of heavy alcohol use, 90 grams per day, for more than 10 years, with the last drink a day prior to the onset of symptoms. He had never experienced liver decompensation before the current episode, and there was no history of gastrointestinal bleeding. At admission, he was alert and oriented to time, place, and person. The physical examination revealed jaundice, spider on the chest wall, palmar erythema, and moderate ascites. Here you have some vital signs. And as you can see, here we have some blood test result at day 1. Total bilirubin at 16, ALT, AST, albumin 28 grams per liter, the coagulation profile, and renal with creatinine 1.1. The screening for viral hepatitis, autoimmune hepatitis, and other cause of liver disease were all negative. There was no history of potentially hepatotoxic drugs use, and the abdominal ultrasound demonstrated dysmorphic liver with steatosis and ascites, but there was no sign of biliary obstruction. So we made the hypothesis of alcoholic hepatitis. Then the screening for infection was negative. So you have here some scores. MEDRI was calculated at 33. The MELD at 23 and Glasgow at 10. Liver biopsy was not performed. The patient was treated with prednisone, and so we have some blood tests at day 7, and so the Leo model was 0.77, and the MELD score was 30. At that time, the prednisone was stopped. Unfortunately, the hospital course was complicated by infection, spontaneous bacterial peritonitis, and he was treated with intravenous antibiotic and albumin, but regardless of treatment, he continued to worsen, developing multi-organ failure. He was admitted to the ICU and died 7 days later. So we have here some question of discussion, and I wonder if you could comment some talks regarding this issue. And the first question is, when should we perform a liver biopsy in alcoholic hepatitis? Which are the best tools to predict short-term mortality in alcoholic hepatitis? And nowadays, are there options other than steroids for severe alcoholic hepatitis treatment? Professor Vijay showed us some good news, but I want to hear from you what you have to do by now. Thank you for your attention.
It's an honor to be here among so many experts that I admire. I congratulate Dr. Leila Beltrão for her successful career, and I appreciate the opportunity to participate. Recently, the Safe Histopathology group developed a grading and staging system for alcoholic liver disease. Before this, the liver biopsy was indicated in cases of possible alcoholic hepatitis when there were confounders together with clinical diagnosis. Safe Histopathology group studied a cohort of 445 patients with compensated or decompensated alcoholic liver disease enrolled for 4 European centers. The histologic steatohepatitis and severe cirrhosis were independent predictors of liver-related events in compensated alcoholic liver disease, as well as liver-related deaths in decompensated alcoholic liver disease. Today, we don't have a different treatment target to histopathological steatohepatitis, but maybe in the future, we will have something different to do on this setting, and maybe we can treat patients who have below 32 MADRI score.
Yeah, maybe Doug, do you want to make some comments?
Sure, happy to. So just going through it, first of all, thank you for the invitation, and it's a pleasure to be here among Brazilians. So thank you for having me. So just regarding the case, I think the first question about the biopsy, and I can comment on our practice, and I think there is some variability across different centers. I think some hepatologists are more aggressive about biopsying everyone, and I think as Dr. Mendes mentioned, there is some potential prognostication that can be made on histopathology, although we're not quite there yet for prime time. So I don't think we can rely on histopathology to predict prognosis yet, but that might be in the future. For now, what we typically use is the NIAAA criteria for the diagnosis of ALCAP, which is essentially mainly clinical and biochemical. Like this patient had pretty much met all clinical and biochemical criteria for ALCAP, so we make a probable diagnosis of alcohol-associated hepatitis in which a biopsy will likely not be necessary or indicated. But again, I think there is some variability across different centers.
I'll just add one point, again, trying to be forward-looking, is that one of the areas that's very good for AI is pathology. And besides the variables that we know are linked with alcohol-associated hepatitis, it's likely that there's many other variables that we don't know and we don't even see on the biopsy. And so we're doing a lot of work in this area now to try to get an unsupervised learning process, how we can understand what may be other variables in the biopsy. And that may, once again, provide some insights from biopsy specimens that currently we don't get in terms of diagnosis and prognosis.
So, hey, Vijay, this is Arun. So can I take a slightly different point of view? And that is what we really want to understand is from a mechanistic point of view in terms of disease drivers, whether it is genetic intersection between obesity, alcohol, activation of the innate versus adaptive immune system, all of the kind of things. What we really need to understand is the molecular heterogeneity. Alcoholic hepatitis is not a disease, it's a syndrome. And so where I think the field needs to go is to be able to better understand in the individual patient, what are the key principal drivers and which might ultimately allow us to move towards targeted therapeutics for individual patients. And personally, I think that would be the bang for the buck, trying to understand molecular pathology rather than just trying to squeeze more out of gross images, using H&E and other usual staining techniques that are 200 years old may not be the best way.
Yes, good. Thanks, Arun. And there's perhaps comparing different diseases and understanding what is there in the specimens from, again, things that we haven't been able to identify histologically using current techniques may help us answer some of those questions, especially comparing NASH and ASH, which, as you've pointed out, has a lot of intersections, and it's probably more of a spectrum in some of the types of models that you've made about ASH and NASH. And understanding if there really may be, although we think that the biopsies look very similar, there may be many features that we don't understand that are quite different that could give us insights into pathophysiology.
So the second question that comes up is, there's this entity that we loosely refer to as walking ASH, right? This is the patient you see in your clinic who's holding a job, family man, doesn't feel so bad, modest elevation of liver enzymes, but drinks a lot. And the biopsy looks like typical NASH, but actually patient is drinking a lot of alcohol. Then there is the person who comes into the hospital with sarcopenia, ridiculously jaundiced, fluorescing at night, just bright yellow. It's hard, we call them both alcoholic hepatitis. It's hard for me to believe that we're describing the same entity. And I personally think that the alcoholic steatohepatitis that we see in the clinic as an outpatient, they're relatively asymptomatic patient, that is sort of some amalgam of this NASH-ASH mix. But the alcoholic hepatitis that brings people into the hospital is a very distinct, acute worsening, or maybe not even that acute. It's a distinct worsening of that state. There's far more cholestasis, and I think the pathophysiology and mechanism of that is likely to have many distinct features from the garden variety, that you would see in an outpatient setting.
Yeah, agree. Doug, any thoughts on Dr. Sanyal's comments?
No, I think it goes back to the role of a biopsy, which I think in the future will be more likely for prognostication and to guide therapy than for diagnostic purposes, except in those patients, as again, Dr. Mendes mentioned, that there are confounders where there is this question of ASH-NASH overlap.
Leticia, welcome back.
Oh, sorry, my internet's not working. We are at the second question.
Yeah.
Okay.
The first.
Okay.
Third now.
Sorry, good afternoon and welcome. We are going to discuss the second question, and I'd like to invite Professor Mário Reis. He is professor of the Federal University of Rio Grande do Sul, and the professor, oh great, okay, to comment two questions. The first, which are the best tools to predict short-term mortality in alcoholic hepatitis? And I'd like to know if mild sodium is useful for alcoholic hepatitis. And the other question, what are the options other than steroids for severe alcoholic hepatitis? Please, Dr. Grady and Dr. Mário Reis.
I don't know if Dr. Grady is still with us.
I don't know.
Yes, he is.
Oh, great.
Okay.
Okay, thank you. I think this case was very, very well pitched to develop the discussion that we're having. And because if we look at the clinical information we have, yes, we could tick a box and say this is acute alcoholic hepatitis, but it's not definitely acute alcoholic hepatitis. And if you want to address the role of a biopsy, in my view, it has to be linked to the therapeutic intervention consequent upon the information retrieved from that biopsy. So for me, this particular case illustrates a dilemma. And I think you could put 10 very eminent hepatologists in a room and get 8 different answers to how to progress. Personally, I think this case suggests that if you are going to intervene with steroids, the case for a biopsy is at its strongest. And at this level, I would advocate biopsy, because a biopsy is still, yes, quite old-fashioned, still quite crude, but it does have a characteristic appearance. So I would be on the side of biopsy prior to giving steroids. In terms of understanding progression, prognosis, we use obviously Glasgow alcohol score, and some people are using the Leo prognostication process. But all of those comments really totally acknowledge the other comments that the status quo is not good enough, and the future will look very different, and that's where science has to take us to a better way of doing this.
Mario?
Okay, thank you, Leticia. Thank you, Leila, for the kind invitation, and congratulations on the Silver Jubilee. This case is very, very good, and it's very sad, in fact, because we are facing all the time patients like that. And this question, Leticia, which are the best tools to predict short-term mortality, I think that we don't have still now a good method to predict it. Madry above 32 or MELD above 20 are more popular methods, but I don't think they are so good. In fact, still, even Lilly, I don't think Lilly is a very good model to exactly predict short-term mortality. I think that Lilly is good to identify patients who do not respond to corticosteroids, and to identify patients who are still in a big problem because they will die, in fact, and you don't have anything to do with these patients now. I think that gene signatures, microbiome profile, maybe extracellular vesicles, microRNAs, and even liver biopsy, I don't know, could be a good candidate. But honestly, we are still far from a good answer for this specific question. This is my opinion.
Okay. Leila, now other questions from the audience?
Any questions to Professor Vijay, Arun, Douglas, anyone? If not, you're going to move on to the second case in the, the second
mini conference, yes.
Yeah, mini conference, Rodrigo.
Yeah. No questions?
Can I just make a quick comment? Or
Sure,
two comments?
Please.
So one, I think you were mentioning that one of the questions you asked was about the MELD sodium, and I just wanted to mention that there was one study that actually Dr. Shah led here several years ago now, comparing MELD sodium with MELD score, and sodium was not found to be a good predictor of outcomes in ALCAP. So it did not perform better than the MELD alone. So we don't tend to use the MELD sodium for prognostication in ALCAP. But I agree with Dr. Reyes that all the prognostication tools we have currently have limitations. We recently did a study which just submitted to the SLD, the liver meeting, comparing different prognostic tools and trying to come up with the new one. And the performance, the statistic across all the different prognostic tools are pretty much the same, around 0.7, so it's still very suboptimal. Ideally, when I get to 0.8, 0.9 eventually, that will be much better.
Okay. Okay.
Thank you.
Now, Luciano, we are going to the second mini conference.
Yes, thank you, Professor Leticia, for moderating together. It's an honor having you here.
It's a pleasure. Yeah.
And I'd like to ask now a great friend of ours, a partner that always helps in the event and has been previously personally to receive, is Professor Rodrigo Vianna. That's actually from Iceland. In the middle of his holidays, we are bothering him, but he managed to give this talk with the northern lights behind him. He managed to put the Aurora Boreal behind him there. It's not the time in the year, but he managed to do it. And he's a director of transplant services, professor and chief of liver and gastrointestinal transplantation at the Department of Surgery, University of Miami, and director of the Miami Transplant Institute. Thanks a lot to having you here again once more. And we'll start the presentation of transplantation in alcoholic hepatitis and alcoholic liver disease.
Bom dia, muito obrigado mais uma vez por esse honroso convite. de estar aqui no Liver Talks. Eu fico muito feliz de estar participando desse evento, que tem sido um sucesso, né? Leila tem feito um trabalho fantástico organizando esse congresso, junto com o Luciano, e as aulas têm sido fantásticas. Eu vou falar inglês para dar oportunidade para o nosso convidado, nosso outro palestrante, poder comentar sobre a aula, e acho que mais fácil até para eventuais outros espectadores que estejam assistindo. Então, we'll be talking about liver transplantation and alcoholic hepatitis, and really discussing it, is it a reality? In general, liver transplantation has been reserved for patients that have maintained sobriety. However, recently, we have seen a change in that due to some improved results regarding the use of livers for patients with alcoholic hepatitis. Now, first, I think we have to be sensitive to the term. I think we all use and we all talk about alcohol and liver disease, and there has been a recommendation to change the term alcoholic to alcohol-associated disease. So alcoholic liver disease will be alcohol-associated liver disease. Alcohol-associated steatohepatitis will be also used, as well as alcohol-associated cirrhosis. The disease manual also reflects and refers to alcohol use disorder and replaces alcoholism, alcohol abuse, and alcohol dependency. I think there's some stigmas there by the name. In terms of the burden that has caused, 38% of the adults worldwide report alcohol consumption within the past 12 months. And globally, the World Health Organization estimates individuals older than 15 years old drink an average of 6 liters of alcohol per year, and that's about 13.5 grams per day. The alcohol has led 3.3 million of all global deaths. So it's a significant portion of deaths associated with this disease. In terms of cirrhosis, is responsible for 1 million deaths. And as you can see, 493,000 deaths were attributed to ETOH. Total per capita consumption here. I see Brazil and the United States about the same levels. Countries more on the north, like Russia, with a very large consumption of alcohol. But indeed, Africa and the Middle East and China, India with less consumption of alcohol due to cultural and religious beliefs. In the US, big problem continues to increase. 67.3% of the adults in the United States drink ETOH. It's more than worldwide, which is about 38%. 8% meet criteria for alcohol use disorder, increasing rates of alcohol use. We see more and more young adults drinking. We see women, minorities, and those of lower socioeconomic status. There's increased economic costs, about 249 billion per year related to alcohol, and 88,000 people died from alcohol-related disease, which is the fourth leading preventable cause of death in the United States. Now, some of the biomarkers, and the reason I'm talking about this is because sometimes it's not very straightforward when somebody has acute alcoholic hepatitis, if that patient has had the use of hepatitis. My other colleague probably commented on some of those treatments and some of the presentations, but usually there is a ratio which AST/ALT more than 2. There's a decrease in ALT activity associated with hepatic vitamin B6 depletion. There's also induced damage by alcohol, mitochondrial damage. And the AST is present in both cytoplasm and mitochondria of the hepatocytes. The ALT in the other way is only found in the cytoplasm. So the ratio decreases following short periods of abstinence because the half-life of the AST is about 18 hours. And GGT is also found in the cell membranes of several body tissues, including the liver and the spleen. Although it's frequently elevated when there is heavy drinking, it's not specific, obviously. GGT could be elevated in anything, basically, that you use in terms of medications or drugs. And typical, you would see macrocytic anemia when there is deficiency of folic acid. Now, to separate also, there has been some indexes created, one of them more recent, which kind of separates steatohepatitis and NASH or from alcoholic hepatitis, and it could give you a more data in terms of predicting the probability of alcoholic liver disease. As you can see here, depending on what you feel on those values, you can have, in this case, close to 100% or close to 100% certainty that that presentation of that patient was induced by alcohol or not by a combination of other diseases. The algorithm for the diagnosis, obviously, usually these patients present with a jaundice. They present to the ICU. They're usually in a coma. You know, there is a question whether you do a liver biopsy. Some centers, when there is clinical and biochemical criteria, the criteria is met, is very clear, and there is a history of an event that happened. There's no need for that. There might be some events that, you know, leads to confusion, and some centers even opt for a liver biopsy. And here's the criteria. So obviously, if you have jaundice within 8 weeks, a known ongoing daily alcohol use, or a binge drinking of alcohol, I always have, you know, my doubts about the binge drinking. Obviously, it could be possible, but most of the people that don't drink and don't have a history of the abuse, they basically pass out before they reach the levels of destruction of the liver. Histological criteria, obviously, if you have some use, continuous use of alcohol that has led to either chronic or acute on chronic, there is inflammation, degenerative changes, and mallory-dank bodies, and sometimes even presenting with some steatosis or fibrosis. Again, this presentation of acute hepatitis, acute alcoholic hepatitis, is probably a lot more rare than we think. Some will come with young adults saying that, well, this person only had a drink. There was the few times that this person was drinking, and the reality could have some other diseases behind or some other addictions behind. It could be a mix with drugs and other things that have actually led to the final disease in the liver. Lab bills, of course, it goes beyond a little bit my discussion here, but there's several prognostic scores, MADRE, talking about liver function, and actually parameters for the use of steroids, others talking about prognosis only. Glasgow alcoholic hepatitis score, I mean, they all help. I think when you put all together, the history and diagnosis criteria, it becomes a lot more likely and more clear what is the problem with that patient. In terms of the algorithm to the management of those patients with alcoholic hepatitis, so definitely you can go by scores, you know, whether you're going to continue steroids or stop steroids, and my colleague probably has comment and all of that. The reality is that sometimes if in the non-responder, you can have a problem, the mortalities are very high. And if this patient then is not reversed, then it becomes liver transplant candidacy, and it proceeds with liver transplant evaluation. So again, I think if patients that respond to steroids, they are in alcoholic hepatitis, I think there is a chance that they will, depending on their score, for example, in the Leila scores less than 0.45, there's a chance, 85% chance they will recover. And if the score is high, then the mortality is high with the 6-month mortality above 70%. And I think those cases, especially in young adults, transplantation should be discussed. Alcoholic liver disease and transplantation has been increasing in the US, as you can see. From 2012, we had 15%, and now we are up to 24%. I think that compensates for the decrease in hepatitis C virus. And obviously, the decrease in hepatitis virus opens the opportunity for other diseases to be discussed. I mean, obviously, NASH increasing, and I think very soon we'll be seeing other indications that previously were completely contraindicated due to the lack of available organs. Public opinion, difficult. I think in this time, in this area, there's always, when you go to the multidisciplinary committee, social workers, there is this opinion about this is a self-inflicted disease. Patient sometimes has a history of continues to drink. But again, you know, hepatitis C or a NASH or some of those other diseases, chronic diseases, could be always self-inflicted. A lot of the patients know that if they continue that type of behavior, risky behavior, or the wrong diet, yes, that they will need a liver transplant. So I think that's part of what we see. And we have to deal with it in a multidisciplinary way, also respecting the fact that using liver transplantation alcoholic patients, especially when they're in a coma in the ICU, could be obviously life-saving. The 6-month rule, there has been a 6-month rule. Most of the programs used to have a 6-month rule, but I think most recently there's a lot of changes in that. There's a lot of scores also talking about it's not about the 6 months, and it could be penalizing some patients unnecessarily. There's delays to referrals to listings. I think there's a lot more regards to social support, regards to previous relapses, and in our center we have not used anymore the 6 months rule, and yet we do an individual evaluation of every patient to see if they could be a candidate or not. The scores have shown similar results when you respect those scores with similar recurrence rates. So liver transplant, you know, it's been always, and that's why actually the title of the talk is Zero Reality. It's been classically contraindicated in a lot of those patients because there is a risk, because alcohol brings risk to relapse. You're using a liver that can be, you know, hard for other patients that have perhaps diseases that will not affect the post-op outcome. Some factors: younger age at the time of liver transplant, a family history of alcohol abuse, shorter period of sobriety, and no prior rehab or outpatient treatment, previous treatment failures, history of polysubstance abuse, presence of other disorders, no social support, cigarette smoking, and the continual use of alcohol despite its consequences. Again, it is rare to find somebody that just had 1 weekend drinking, and I'm not saying it's not 100%, but there was just drinking one time and end up in the hospital with acute alcoholic hepatitis. Usually there is a binge drinking on top of abuse of drugs and alcohol. There is no one factor that can predict the relapse after alcohol and liver transplantation. There is a combination of factors, but no single factor can give us that answer. And again, going back to the algorithm, we face when I think it's when we face a possible disease that could have a 70% 6 months mortality. I think we have to be very, very conscientious of thinking hard of giving this patient a chance. This is a classic paper that came out in 2011 and really it was a French paper, you're all familiar with it, talking about early liver transplantation for severe alcoholic hepatitis for 7 centers from France and Belgium. They compared the survival between patients who underwent early liver transplant with matched with the patients who did not. And the severe alcoholic hepatitis was defined as MADRS above 32. Selected patients with severe alcoholic hepatitis deemed candidates for early liver transplant. So they were non-responders to medical therapy, as I showed. Severe alcoholic hepatitis as the first event for the decompensation of the liver. They had family support, no other coexisting psychiatric disease, and there was an agreement by the family support and family to adhere to a lifelong abstinence. So they actually pushed those patients forward, and I think this could be used as a landmark paper that changed the fact that those patients were denied liver transplantation prior to that. Here, the 6-month survival rate, early liver transplant with controls. So any benefit for early liver transplant supported that 90% of the deaths among control patients occurred within 2 months after the identification or non-responsive medical therapy. So that's why the early indication of liver transplant. And only after transplant, only 3 out of 26 patients had an alcohol relapse after 2 years. So it was a very promising study showing that we could actually, in this, if the criteria that we just showed was met, patients could be candidates for liver transplant. Here's survival rates. Again, mortality without transplant up to 70%, and here post-transplant outcomes in 1 and 3 years, and sustained alcohol use after transplant had poor outcomes. So again, I think this is one of the papers. Again, this is the American Consortium, also with very similar results here, 147 candidates. So really both the French study and the American study showing that if we meet some of these criteria, we should actually push forward for those patients. Here again, liver transplant survival compared to post-alcohol and the patients that were discharged with alcohol relapse. So showing a benefit of transplantation, early transplantation in the alcoholic disease. Some of the p-values, obviously age was one of that. Other scores, sustained alcohol use, post-liver transplant. The multi-center that was done here used 4 pre-liver transplant variables to identify patients at low risk after liver transplant. So whether the patient was using more than 10 drinks a day at the initial presentation, multiple rehab attempts, prior alcohol-associated legal issues, and prior illicit substance abuse. The SALT score, less than 5, predicted 95% that the patients would sustain alcohol use following liver transplantation. So again, if you met all those criteria, there was a bigger chance that there's going to be a relapse after transplantation. Post follow-up, I think, again, both studies show similar results. The relapse is not by itself just a poor outcome. All these other factors associated with the poor family support, problems with the law, no commitment from the family, I think they also play a role in the long-term results of liver transplantation. About 10% of the patients in the study resumed some harmful drinking 1 or 2 years after liver transplant. That didn't result in the loss of the liver. However, we all know that the abuse of alcohol after liver transplantation can lead again, and is very well documented, that can lead again to fibrosis and cirrhosis. In post-transplant setting, the severe abuse of alcohol can lead to fibrosis and cirrhosis in as little as 5 years. But again, you're giving these people that we're talking about, some of them are facing death. You could say the same. Some of the patients with NASH that establish a poor quality of life and the same type of behavior, or patients that acquire hepatitis C by drug use, some of those diseases can come back. Some of our young patients that refuse to take medications and lose their liver to chronic rejection. I think if we're very strict and in a way almost punishing people for what they would do in the future, we end up we don't give them a chance of surviving that acute episode. And again, showing similar results: alcoholic hepatitis and alcoholic cirrhosis with the same, basically the same 5-year result. Obviously, with the good results, I think many European centers after the French study are now loosening the restrictions. You can see in the United States that an increase in 2005, we're doing nobody with alcoholic hepatitis basically. And I think in 2021, for those who present with this situation, more than 50% now have a chance to have a liver transplant. National trends and outcomes. Again, this is the National Scientific Registry. You can see the 1 and 5 year survivals are very similar and can be comparable. Obviously, take into account if the patient is in a stage that needs liver only or liver kidneys. But results very compatible, and results for liver transplant have been improving, and we now see routinely 1 year survival above 90%. Here, most of those transplants have been performed in the northeast part of the country. Some more papers after that. Those are very recent, just confirming, and I think talking about the 1 year morbidity following liver transplant and alcoholic hepatitis. There is some papers talking about some readmissions and a little bit more of complications related to the transplantation alcoholic liver disease. But the reality is that in patients where this selection of the patients maintain some of those criteria we just mentioned, I do believe that we should give a chance for those patients with alcoholic hepatitis, showing compatible results with patients with chronic alcohol disease. Obviously, we need further studies. What is the timing? For how long you should use steroids? How much if you have extremely high MELD scores? What are those studies? We need more multi-center studies in order to say for sure what is the ideal time to indicate transplant. So the take-home points, I think it's important for us to understand that the alcoholic-associated liver disease, it's a big spectrum of diseases, and sometimes we only face that short period of time when the patients are in the ICU. There is obviously the importance of the support, and I think social support and commitment from the family is important. The 6-month rule, I think, going away a little bit, only the acute phase, it should be reevaluated. And there has been very good, excellent outcomes of liver transplantation after alcoholic hepatitis and liver transplantation for selected patients. Again, we have to follow some of those criteria in order not to be wasting organs and creating a burden in the system. Thank you very much.
Thank you, Rodrigo. I think I'll call Professor Leticia to present the next presenter for the case report, and then we will have the debates. Thank you.
Thank you, Luciano. Now we are going to have the second clinical case, who will be presented by Professor Chiara Kingdom from the University of Rio de Janeiro, Federal University of Rio de Janeiro. And after the case, we have 4 questions, and I'd like to invite Dr. Renato Silva. He's Professor of Surgery and Transplant at the School of Medicine, São José do Rio Preto. Dr. Professor Joseph Huygens from the Federal University of Ceará. He's a professor of surgery and transplant too. And Dr. Rodrigo Vianna. We have 4 questions. All the debaters are invited to comment, but please, shortcomings to all of you can speak, okay? Chiara, please.
Just adding, Professor Leticia, that Dr. Renato was also the best chief. That was my chief in Rio Preto, where I trained. And also did his training here in Birmingham with Paul McMaster here in the UK. And
okay.
Is a full professor by Unicamp.
I didn't have this in the document. Sorry, Dr.
Yeah,
Renato.
no, just informally.
Okay.
Professor Renato.
Okay. Chiara, please.
Okay. Good afternoon to all. First of all, I would like to thank for this opportunity to be here in this meeting, and to congratulate Professor Leila Beltrão for the 25 years of Hepato Pernambuco and for all contributions to the Brazilian hepatology. 38-year-old male was referred to a hepatologist to evaluate elevated liver enzymes. He reported jaundice in the previous 3 to 4 weeks, mild lower limb edema and loss of appetite with no other associated symptoms. He had a past history of obesity, diabetes diagnosed 2 years before, and also a diagnosis of cirrhosis in the last year, but with no medical follow-up. He denied any previous hospitalization or medical condition. Regarding social history, he reported a significant alcohol intake since the age of 16 years of approximately 300 grams per week, mainly in the last 6 months. No history of smoking or drug abuse. His AUDIT-C score was 9. On physical examination, he was a grade 1 obese patient with a good general condition, lucid and oriented to time and place. He had no anemia, was hydrated, but presented the jaundice. Vital signs were normal. He presented pulmonary erythema and telangiectasias on trunk. Normal exam of cardiovascular and respiratory system, and regarding abdominal examination, he presented normal liver size, but spleen enlargement and no ascites. There was no flapping, but mild lower limb edema. Lab results performed 3 days before the medical visit demonstrated a mild anemia and leukopenia with a significant plaquetopenia. In comparison to labs results performed 4 months before, he presented an increase in INR to 1.7, increase in bilirubin level to 4.3, with direct bilirubin predominance and a decrease in albumin levels. He also showed an increase in GGT levels and about 2-fold increase in aminotransferase levels. Abdominal MRI performed just after blood test showed a normal liver size with characteristic of chronic liver disease with no biliary tract dilatation or calculi. There was spleen enlargement and extensive explanation and abdominal wall venous collateral circulation with recanalization of paraumbilical vein and absence of ascites. He was classified as a Child-Pugh B7 patient and MELD sodium score of 19. Additional exams were requested to investigate other etiologies for liver disease, and viral, autoimmune, and metabolic etiologies were excluded, as well as biliary tract obstruction or active infections. Based on the history of continuous and abusive alcohol intake, and after excluding other etiologies, a diagnostic hypothesis of cirrhosis complicated by alcoholic hepatitis was performed. Prognostic static assessments for alcoholic hepatitis were evaluated, and he presented a MADRI score of 41.1, a MELD sodium score of 19, Glasgow score of 7, and EBIC of 5.7. Considering a MADRI score above 32, prednisolone 40 milligrams a day was initiated. This approach may increase short-time survival of 30 days, but this increase was not demonstrated in 3 or 6 months. At a day 7 of prednisolone use, Lilly score was calculated, demonstrating a value of 0.32, which represents a low-risk mortality in 6 months. On the 18th day of prednisolone use, he was hospitalized with upper GI bleeding. Upper digestive endoscopy demonstrated the presence of 5 large caliber varicose cords with head signs and recent bleeding and marked portal hypertensive gastropathy. Varicose band ligation was successfully performed, and telepressin and prophylactic antibiotics were initiated. Abdominal ultrasound with Doppler at admission showed the same chronic characteristic with no evidence of ascites or portal vein thrombosis. This slide shows patient evolution after prednisolone use. After GI bleeding and during hospitalization, he developed a pneumonia, encephalopathy, and acute and chronic grade 2 liver failure. Prednisolone was progressively reduced, and he remained in hospital for 12 days and was discharged for outpatient follow-up and referred to a liver transplantation center. During follow-up, he presented a progressive increase of MELD sodium score, achieving a score of up to 32, which represents a mortality probability of 52.6% in 3 months, and was discharged with a MELD sodium score of 25, which still represents a mortality probability of around 20% in 3 months. In summary, we have a young male with a cirrhosis complicated by a first episode of alcoholic hepatitis and acute and chronic liver failure after GI bleeding and pneumonia with around 2 months of alcohol abstinence. He has a good familiar support, no history of other drug addiction, and at the moment, he is a child classification C with 11 points and a MELD sodium score of 22. I would like to point out some questions for discussion. Should we consider a liver transplantation in this patient before completing 6 months of alcohol abstinence? Which is the best patient profile with alcoholic hepatitis for liver transplantation, and how should selection occur? How early should a liver transplantation be indicated based on the assessment of non-response to corticosteroid therapy? Is there a role for living donor transplantation in alcoholic hepatitis? Thanks for your attention, and we can go to the answers. Move to the answers.
Nice case, Chiara. And I would like to invite Dr. Renato Silva to answer the first question. Should we consider a liver transplantation in this patient before 6 months of abstinence, means early liver transplantation? And I would like to question, do we have in Brazil legislation that allows us to meet early liver transplantation in that situation?
So, good afternoon, everyone. It's a pleasure to me stay here. Thank you very much, Professor Leila, for this silver jubilee. It gives for us one important meet like this one. Of course, that should be, but not here in Brazil. because in Brazil, by the law, we follow 6 months rule. Okay, so it's really when patient that have severe liver disease, severe portal hypertension, what we do in this case in Brazil, if it's impossible for us to perform liver transplantation. Sometimes we discuss chips in this patient because he had very severe portal hypertension. But when we look always published data, this kind of this patient, when we perform chips, we have high mortality because this patient is child C, its MELD is so high. So what is interesting that recently the Brazilian Hepatology Society make a survey. The members of this Brazilian society vote against move the rule, the 6 months rule. So these patients, yes, I think that's true before the pandemic, to unpublished data, okay? Unpublished data. So, but I think that is when one patient that have high risk to mortality, but now we can offer the opportunity for this patient perform liver transplantation. But I agree that this patient should be evaluated for to do it.
Any other one comment?
May I, Leticia?
Hi.
Yeah,
please.
I think that we should fight against this rule in Brazil because it's terrible to not offer to these patients the best treatment you have, that is liver transplant. So I think that we need to move, try to move this rule out, discussing it with the National Transplant, I don't know how to say, Leila, Câmara Técnica,
Technical Committee.
Ok. Because...
Mário, eu acho que agora a gente pode falar em português. Vijay pediu para sair, então a gente pode falar todo mundo em português.
Ótimo.
E o Brave também saiu?
Tá.
Okay.
Eu acho que
eles pediram para sair porque a gente ia terminar de 2 horas, eu dei mais 15 minutos para ir mais à vontade.
Muito bom. Agora vamos começar.
Essa regra é absurda, nós temos que ir contra essa regra. Eu falei esses dias com a Ilka, que é uma das pessoas que fazem parte dessa Câmara Técnica, tu fizeste muitos anos, eu também fiz. Nós temos que ir contra isso aí. O Huygens está aqui. O Huygens, tu tem que acabar com essa regra. E se a Sociedade Brasileira de Hepatologia, os membros foram contra, é porque a maioria dos membros não estão nem aí para transplante, nem se importa.
Eu defendo isso há anos, quando eu quis fazer em 1990 o primeiro caso de hepatite alcoólica. Então, eu venho defendendo isso há muitos e muitos anos, mas, Mário, somos votos vencidos junto aos cirurgiões.
Ok, Mário. Só um comentário aqui, Mário, ainda em relação ao que você falou, que é verdade. Só lembrando que essa discussão é antiga, que o ano passado foi feita uma enquete, SBH, a BTO, justamente para tentar reduzir esse tempo de abstinência que a gente esperava que baixasse pelo menos para 4 meses. Qual foi o resultado da enquete? Mantém os 6 meses. Então, realmente, voltando para esse paciente aqui, se você for olhar...
Não representa quem lida com o transplante.
Então, uma coisa aí, Huygens.
Voltando aqui,
só quer fazer regra boa para carcinoma hepatocelular.
É
isso aí, concordo.
Então, voltando aqui, esse caso agora apresentado, com hipertensão porta grave, com MELD alto, com 2 meses de abstinência, com suporte familiar importante, né? Claro que você pode abreviar. Eu acho que a gente teria que discutir, não 6 meses, 3 meses, talvez, porque vocês, hepatologistas, sabem muito mais que o cirurgião, qual o tempo necessário para você ver se aquela doença hepática vai melhorar com a abstinência e não precisar do transplante. Talvez não sejam 6 meses, 3 meses, né? E os resultados aí da hepatite fulminante mostram que a volta, a recidiva do alcoolismo é igual, né? Na hepatite alcoólica e no paciente transplantado com 6 meses de abstinência. Então, eu sou plenamente favorável a estipular um tempo menor, até porque, recentemente, nós perdemos 2 pacientes jovens no nosso serviço, um porque faltava 15 dias para 6 meses, morreu com hemorragia digestiva, e o outro faltava 1 mês, porque a nossa câmara técnica aqui é igual ao critério de Milão, 6,1 centímetros você não pode transplantar. Então, Com 5 meses, 29 dias também não pode. Então, realmente o problema de lá esse corte, esse cutoff, seria 3 meses, seria 4 meses, porque você tem que obedecer também, porque se não for 3 meses, 2 vai ser a mesma coisa do Milão. Milão 6.1 não pode. Mas a minha sugestão é reduzir esse tempo. Não 6 meses, talvez 4 meses ou 3 meses.
Ô, Isne, dá licença aqui. Desculpa, Letícia. Você que é
só queria te perguntar. Não, só queria perguntar uma coisa a vocês. Eu acho que essa falta de apoio para se fazer o transplante precoce é muito por falta de conhecimento do hepatologista sobre doença hepática alcoólica, assim, da vantagem de você preencher os critérios e beneficiar e não deixar o paciente morrer. Aí a minha pergunta é, qual é a porcentagem desses pacientes, se a gente tem algum survey aqui no Brasil, que tem a hepatite alcoólica grave, que preenche os critérios, vai tirar muito o fígado de quem não tem carcinoma hepatocelular, de quem tem a forma fulminante, mas não está relacionada ao álcool? Vocês sabem qual é a porcentagem? É 5%? É 2% daqueles com hepatite severa que preenchem os critérios para fazer um transplante precoce?
Letícia, eu queria depois acrescentar a opinião, como Rodrigo e Douglas conseguiram, nos serviços dele, implantar essa possibilidade de fazer o transplante sem esse tipo rígido, para que a gente troque essa experiência e tente, né, a gente está aqui na plateia, o Igens é um dos centros maiores transplantadores do Brasil, é o atual presidente da Sociedade Brasileira de Transplante de Órgãos, para que a gente veja um caminho para que esses pacientes sejam beneficiados, às vezes, muito mais do que um paciente com carcinoma com 2 centímetros.
Certo.
Veja, Leila, eu acho que o tempo em si, acho que a gente não deve colocar um tempo, né? Claro que você não vai transplantar o cara em 15 dias, porque você vai ter que até avaliar outras situações. Mas eu, por exemplo, eliminei o tempo aqui. Se você pega vários papers recentes, com scores, com apoio familiar, o resultado do transplante é o mesmo, né? Então, você vai para aquela mesma discussão. O alcoólatra não pode, mas o cara que come e volta a ter NASH pode, o cara que usa droga pode. Então, acho que a gente tem um estigma no alcoólatra. A doença hepática, na maioria das vezes, ela é self-inflicted. Se você se comportar bem, você não vai ter doença hepática, a não ser que você pegue uma doença, uma hepatite e tal. Então, acho que vai muito mais para você fazer, em vez de ficar só discutindo o álcool, o que eu fiz aqui foi discutir o resto. É muito pior você transplantar um cara que não tem suporte social, que não toma remédio, que não sei, do que transplantar um cara que está bebendo e que tem suporte familiar. A gente sabe isso em qualquer indicação, né? Então, você fala, vai jogar fígado fora? Então, não vai transplantar o cara com NASH, que não tem suporte familiar. Então, acho que esse não é o caso, né? E acho que talvez um step antes porque a opinião pública do Brasil, eu não sei como é que funciona isso, seria, de repente, poder abrir a discussão na Câmara e falar assim, não é fechado para 6 meses. De repente, se você mandar um caso e falar, tem suporte familiar, não respondeu ao tratamento, é jovem, a Câmara, de repente, poderia autorizar o transplante. E aí analisar isso por 1 ano e ver, assim, quantos nós perdemos, quantos nós salvamos, né? E aí, então, partir de novo para a opinião pública. Não sei, de repente, a gente vai querer fazer uma coisa, assim, imediata. Mas eu tirei o tempo aqui como se fosse... A gente nem fala muito tempo, a gente fala em tudo em volta do alcoólatra, né? Não só do tempo.
O Rodrigo, sua pergunta, quer dizer, nos Estados Unidos é livre, a equipe decide, não precisa passar em nenhuma câmara técnica, você pode transplantar o paciente, seria 1 mês?
Na verdade, nos Estados Unidos pode transplantar qualquer coisa, né? Eu posso listar um cara amanhã. O que acontece é que você não ganha ponto e que se o resultado for ruim, eles vêm e fecham o seu programa. Mas aí que tá. Então, no Brasil tem que ter várias outras coisas, né? Porque daí todo mundo vai ilustrar o alcoólatra. Então, eu acho que tem que ter, eu acho, né, a sugestão, eu acho que, de repente, poderia abrir. Aqui a gente decide, o programa decide, né? Então, se todo mundo concorda, problema. Aí agora, se o cara perder o fígado, a gente vai perder um fígado, né? Então, acho que, de repente, como no Brasil a regra é mais restrita, de repente abrir para as câmaras regionais para talvez avaliarem esse paciente, porque eu acho que nem avalia, né? Se não tiver 6 meses, a regra é clara, né? Como diz, não vai. Então, talvez abrir essa discussão, né?
Eu acho que precisa ter essa discussão com a sociedade, primeiro com a sociedade médica. Não adianta a Câmara Técnica lá, tem que juntar gastro, hepatologia, os transplantadores, e nós propomos ao Ministério.
Isso.
Né? Não vai conseguir abrir assim como você tem essa liberdade, nós não temos. Então, não vai conseguir. Respondendo à tua pergunta, Letícia, os trabalhos que eu tenho lido têm impactado 3% aí fora. Então. Apenas 3%, é um número muito pequeno quando você faz essa seleção. E enquanto nós estamos transplantando aí o doente que tem 2 centímetros de HCC, que depois que a gente é um trabalho para achar esse tumor lá, com tantas possibilidades de cura, esse doente não vai morrer. Ele não tem morte imediata, o doente com câncer. Ele vai sobreviver, vai sofrer muito. Agora, esse que foi apresentado agora vai morrer. Então, eu queria pedir ao Wiggins, a Leila, enfim, a nós, que nós vamos nos juntar, vamos fazer um meeting para isso, convocar, Leila,
Acho ótimo,
as sociedades para decidir isso e sugerir ao Ministério. Não adianta só Câmara Técnica, nós temos que decidir isso e sugerir ao Ministério. Não tenho dúvida que o Ministério vai aprovar. Eu acho que esse é o primeiro passo que nós temos que ter. Não temos, Rodrigo, essa liberdade que você tem aqui, e não acredito que a opinião pública vai ser contra. Né? Nós mostramos o resultado, o povo brasileiro é generoso, ele não vai ser contra isso.
Mas, Renato, eu falei de Câmara Técnica, porque a minha dúvida é o seguinte: claro que eu acho que as sociedades médicas, hepatologia, gastro, cirurgiões de transplantes, médicos, vão sugerir isso. Mas primeiro vão sugerir o quê? Né? Que você possa transplantar o cara. Mas qual é a regra? Tem que ter regra, porque os caras abusam. Eu acho que talvez as sociedades sugerem que a Câmara Técnica avalie os casos, né, como um suporte, porque acho que se você for no Ministério e falar agora pode transplantar o cara com álcool, mas daí pode transplantar quem, né? Tem que ter um pouco de regra. Então, acho que tem que passar pela Câmara, mas com suporte
essa regra, eu acho que não deve ser a Câmara. Essa regra, as sociedades devem dizer quais são as regras. E aí levar para o Ministério. Não é dizer, eu vou transplantar, não é isso. Nós vamos propor, vai juntar todos nós transplantadores, gastro, hepatologistas, e vamos propor, o Brasil vai propor, a BTO vai propor, a SBH vai propor. Nós vamos propor. Sem regra, não tem jeito. Aí vira uma bagunça.
Eu queria só fazer uma proposta, que eu vou ter que sair agora, que eu tenho um compromisso 2 horas, já estou atrasando, mas não podia fazer logo agora, convocar um webinar, a BTO com SBH, justamente com esse tópico, tempo de abstinência no transplante. Não é nem especificamente... entendeu? Aí sim...
Tem um comentário da Rita aqui, que é muito importante, que ela participou disso, tá? Eu acho que todo enquete, você faz, apesar da sociedade ter votado isso, né, ela comenta aqui, a Rita Silva, a Mônica também aqui no chat, tem várias pessoas comentando, é que quem participou desse enquete não lida diretamente com esses pacientes. Então,
exatamente, não tem noção.
Eles não representam a quem está diretamente ligado. Então, acho que você tem que tirar uma câmara, como a gente tem dentro da SBH, de pessoas que lidam para o transplante. Essas pessoas é que teriam autonomia para poder lidar e poder...
Exatamente. Por isso que eu estou achando ainda que a saída seria esta, convocar, é possível fazer hoje um webinar com a SBH, BTO, convocando pessoas que lidam diretamente com isso, hepatologistas, cirurgiões de transplantes, aí sim, fazer uma proposta, amadurecer e enviar para o Ministério da Saúde, porque isso aí não precisava de portaria. Eu concordo com o Rodrigo Vianna, que no Brasil também você não pode dizer, não vai poder fazer. Não, esses casos poderiam ser enviados para a Câmara Técnica, justamente para analisar, baseado no perfil de... social, se for o primeiro episódio, né? Se não tem muita comorbidade, se é um paciente jovem, aí sim, isso não precisaria nem entrar em portaria, que demora muito, era somente essa autorização, já que eles seriam transplantados, na maioria das vezes, pelo MELT, eles não entrariam em critério de exceção, eles teriam transplantado pelo MELT. Né?
Eu acho que é isso aí. Isso aí resolve mais rápido, pelo menos agora, né?
Eu vou pedir licença para sair, com o
a gente tem 5 minutos para poder...
exatamente.
A vontade começou grande dessa discussão, porque eu sabia que era uma coisa que ia dar muita...
Ficou ótimo. Só para pedir licença à Chiara, a segunda e a terceira questão já foram respondidas nesse debate, e uma questão que eu acho interessante colocar, de se teria algum papel... Fica aí, professor José, fica aí. Se teria algum papel para o transplante intervivos nesse caso de hepatite alcoólica severa? Tem algum papel?
Assim, o nosso grupo, nós vamos completar agora 2.000 transplantes, mas não fazendo intervivos, nós estamos fazendo simulador falecido. Então, eu não sei se o Rodrigo Vianna, agora pela legislação no Brasil é permitido, porque não existe uma legislação específica para doador vivo. O problema é que não seria remunerado pelo SUS, provavelmente, mas não está indicado, porque você utiliza um órgão que não é público, não é do sistema, né? Então, não há contraindicação, não há lei que proíba o transplante intervivo, como, por exemplo, você pode fazer transplante intervivo e é feito no Brasil, além do critério de Milão. Aí fica, sim, a critério de cada equipe.
Quando é intervivos, o SUS não paga, é isso?
Depende, não. Se for, depende de algumas situações. Por exemplo, coloretal, metástase coloretal ele não paga,
tá.
Não está na indicação. Mas creio que a alcoólica, sim, porque não está dentro da indicação, entendeu? Para a regra. Por exemplo, colangiocarcinoma hilar, metástase coloretal, ele não remunera porque não está presente na indicação da última portaria.
Entendi.
Mas você sabe que
Professor Renato?
Esse negócio do intervivo, eu uso muito DCD, né? Doador de coração parado. Inclusive, esse ano, vou mandar um paper logo, a gente aumentou de 15% para quase 40% o uso de DCD, né? Mais do que o UK em Miami. Mas eu tenho um pouco de problema, às vezes, com o doador vivo, que você fala que não pode usar o cadavérico, né? Que você vai pegar um órgão de um cadáver, mas pode usar de uma pessoa viva, né? Então, é muito interessante como é que o ser humano pensa, né? Não, vamos pegar de um cara sadio lá, porque essa indicação é meio assim, mas do cadáver não pode. Então, também é tudo errado, né? Vamos arriscar a vida daquele cara lá, mas do cadáver não, imagina, pode usar para outro, mas o cara vai morrer. Então, eu não sei, esse troço intervivo, acho que se você não vai fazer o transplante, você não devia fazer nem intervivo, nem cadavérico. O cara tem indicação ou não tem, né? Não tem indicação, então usa o intervivo. Pior ainda, eu acho que é pior ainda fazer isso. Né? É mais antiético que qualquer coisa. E é o que acaba acontecendo no mundo, né? Tá tudo errado, né? Não.
Letícia, Douglas tem um comentário aí. Eu acho que Douglas, Letícia, tem um comentário para fazer.
É que eu não consigo ver aqui no tablet, por favor, fala aí para mim.
Posso falar?
Pode.
Depois o Douglas fala, porque a gente já vai ter que encerrar.
Primeiro, Letícia, esses transplantes que são feitos fora das normas não têm direito a retransplantes também pelo SUS, tá bom? Isso é bom esclarecer. E a outra coisa, eu sou contra transplantes intervivos. O princípio da medicina é, primeiro, não fazer mal. É o que o Rodrigo falou. Eu tenho uma pessoa doente que está morrendo, aí eu faço uma doença no outro. Vou lá, faço uma hepatectomia. Uma hepatectomia tem uma mortalidade de 5%, fora a estenose. E uma coisa mais incrível, é o único órgão que se regenera. Às vezes, não é hepatectomia para doador, o órgão se regenera, o doente fica cansado. Então, isso é um absurdo. O MELD trouxe uma coisa muito ruim para o mundo. Nos Estados Unidos tem trabalho que mostra que se a pessoa que morreu teve 5 ofertas de bons fígados e não quiser, porque se fica, não, vai aparecer o melhor. Aqui em São Paulo, 1.000 fígados por ano nós não usamos. E agora nós vamos entrar em uma nova era, que é a era da machine perfusion. Aí não vai ter desculpa para você estar agredindo alguém fazendo transplante intervivo. A única chance que cabe em minha cabeça com intervivos seria para uma criança logo 2 e 3, mas fazer uma hepatectomia, só o cirurgião sabe o que é uma hepatectomia. É uma grande cirurgia. E para finalizar, tem um trabalho muito interessante aí dos Estados Unidos, que as seguradoras fizeram. Né? A mortalidade é 0, é 3, 4, 5%. Aí a seguradora foi no atestado de óbito e viu que é maior. Entendeu? Então, não dá. Imagina se eu fizer um transplante. Eu fiz 3 aqui. O último, quando eu saí, eu disse, olha, nunca mais vou fazer isso na minha vida. Imagina você pega uma pessoa sadia, leva para uma cirurgia e morre. O que é isso?
Não tem jeito.
É muito complicado.
É horrível.
Eu estou com o Rodrigo. Usa o marginal dono.
Tem que o Lúcio Pacheco aqui comenta que o transplante intervivo tem as mesmas indicações aqui no Brasil.
Posso fazer um rápido comentário só para dar um pouquinho de esperança e motivação para o grupo? O doente foi transplantado depois de 3 meses de abstinência, na verdade, mais ou menos 1 mês após a alta hospitalar, e está indo muito bem, sem retorno ao uso do álcool, com os exames todos normais. Então, eu acho que isso dá um pouco de ânimo para o grupo.
Quem autorizou?
Foi na Câmara Técnica do Rio de Janeiro.
Ele autorizou com 3 meses de abstinência?
Com 3 meses.
Então, o Brasil também precisa ter que seja homogêneo, né? Não pode ter essa diferença de estado para estado, né? Então, se está certo ou errado, eu acho que nós precisamos, como no Brasil nós sabemos que em São Paulo as regras são diferentes do resto do Brasil. Em primeiro lugar, a gente tem que ter uma regra para o país inteiro, né?
Claro.
Que está errado o Rio, entendeu? Então, ninguém precisa ter a mesma regra.
Sim.
Você vê, Rodrigo, por que tem que ter regras, né?
Isso.
Rígida,
mas é o que eu falei, tem que ter uma... Porque senão tem que ter regra, mas tem que ter alguma... Sei lá, tem que ter um bom senso primeiro, né? E aí... Você sabe o que eu acho que eu acho que é o princípio de tudo isso? É que não existe transparência e controle de resultado. Enquanto não existir isso, porque se eu começar a listar casos que o cara vai morrer, o meu resultado vai cair, aí eu não vou listar mais. Então, vai desde o começo. Aqui a gente tem um órgão que controla a nossa sobrevida enxerto de paciente e tal. Então, enquanto não tiver isso, daí sempre vai ser bagunçado, entendeu? Eu acho que começa por aí.
No Brasil, se um serviço fizer 20 transplantes e morrer 16, isso não é nenhum problema. Não há ninguém.
Para finalizar, eu só preciso...
o cara do álcool.
Para finalizar, Douglas, bote a experiência que vocês tiveram aí em 2019 nessa reunião do ESLD, o ITS.
Isso. É só para comentar como a gente fez aqui, a gente fez uma conferência em 2019 em Dallas, que foi publicado no Liver Transplantation até. Era uma reunião que teve hepatologistas, cirurgiões de todo o país para criar um consenso. Foram 2 dias de conferência com discussões, debates, e a gente criou 8 critérios para early transplantation para alcoholic hepatitis. Algo semelhante no Brasil talvez seja benefício. Não tem nenhum tempo, não tem nenhum dado que eu conheça que mostre que o tempo de abstinência prediz ou predict outcomes depois do transplante. Então, a gente não tem nada de tempo de abstinência para listar para transplante. A gente faz transplante para ALK-HEP aqui já faz 3 anos e meio, e nós tivemos somente um caso de relapso depois de transplante, sustained relapse.
É isso aí, concordo. O tempo não tem nada a ver.
A Liliana está com a mão levantada. Professora Liliana, tem um comentário final.
Eu acho que era isso que a Letícia... Não, foi a pergunta da Letícia que ela acabou fazendo, que era sobre os interviews.
Tá.
Pessoal, eu acho que falta para vocês aí.
Valeu.
Obrigado.
Pessoal, eu tenho, antes da gente terminar, Rodrigo, espera um pouquinho só, eu tenho um filme...
Tô aqui.
De fechar a aula aqui, eu queria agradecer a todo mundo. É com emoção que a gente termina mais um Liver Talks do Hepato Pernambuco 2021. Esperamos que para o ano a gente possa estar hibridamente, mas todos juntos. Eu revendo algumas fotos para montar isso, aquela vontade de abraçar, de discutir pessoalmente, bater uma nostalgia. A gente tem um vídeo de encerramento e eu agradeço a todos. 78 pessoas participando, com 98 aqui na sala. Então, acho que foi mais um meeting que a gente espera de sucesso. Isso tudo a gente agradece a vocês, ao empenho das sociedades, aos nossos patrocinadores e a todos que contribuíram durante todos esses 25 anos para fazerem a história do Hepato Pernambuco. Tá? Com isso, eu encerro o filme assim, Rodrigo da SBT. Eu agradeço também a toda essa tecnologia montada, a Lani, que está há anos nessa coordenação, a minha universidade e ao Instituto do Fígado, que estão sempre junto conosco. Tá? Obrigado, pessoal. Um filme aí e até logo, até breve.
Can look into my eyes and see the way I feel and how the world is treating me. Maybe I have known you forever. Amigos para siempre means you'll always be my friend. Amigos para siempre means a love that never ends. Friends for life, not just a summer or a spring. Amigos para siempre. I feel you near me even when we are apart. Just knowing you are in this world can warm my heart. Friends for life, not just a summer or a spring. Amigos para siempre.
We share memories I won't forget. I will share more, my friend. We haven't started yet. Something happens when we're together.
When I look at you, I wonder why there has to come a time when we must say goodbye. I'm alive when we are together. Amigos para siempre means you'll always be my friend. Amigos para siempre means a love that cannot end. Friends for life, not just a summer or a spring. Amigos para siempre. work and warm my heart. Friends for life, not just a summer or a spring. Amigos para siempre.